And live. Yes.
Okay, thank you. Good evening, Kenya. My name is Susan Bogo. I'm a renal nutritionist specialist by a Nutrition and Dietitian Academy. I'm also a clinical nutritionist in Kirinyaga County. Today, I'm presenting to you a case by the name acute kidney injury. Before I present the case, there is an outline of what we are expecting in the case. We have the introduction to the acute kidney injury. I'm going to define it. I'm also going to classify acute kidney injury. I'm also going to explain about signs and symptoms of acute kidney injury. Also explain the factor predisposing a person to acute kidney injury, the causes, complications, the test, treatment of the acute kidney injury, drug treatment, nutrition, the goal of nutrition in the management of acute kidney injury, and the monitoring checklist of the acute kidney injury. You're much welcome. In the introduction base, it's very good to understand what is acute kidney injury. Acute kidney injury is prevalent in both the developing and non-developed countries. It is associated with severe morbidity and mortality. Worldwide, 1 in 5 adults experience acute kidney injury during a hospital episode of care, thus raising a concern and awareness among healthcare workers. Acute kidney injury can be defined as a decrease in renal function, resulting in renal insufficiency. The decrease in renal function leads to retention of the nitrogenous waste, of waste such as blood, urea, nitrogen, creatinine, among others in the body. This decrease in renal function results in stages such as the prerenal, intrinsic, and obstruction of the urine flow in the kidneys. For you to understand about acute kidney injury, it's very, very important to understand about the kidney nephron. In the body, we have got millions and millions of the kidney nephrons, which help, in a layman's language, like washing the toxins in the body. Kidney plays a very vital role in our body. What you take passes through, but there are some things which don't pass through the kidney. So not all of them passes, but the one we know most passes through is like things like glucose. Things which don't pass through is like the red blood cells. And once they pass through, there is a problem in your body or the kidney is already damaged. We go further with the definition of the acute kidney injury. It may be severe due to several illnesses, and acute kidney injury can be defined in serum creatinine of less than 26.5 millimole or greater than 0.3 milligram per deciliter within 48 hours. In other definition, it can be a serum creatinine greater than 1.5 times baseline. which is assumed to have occurred within 3 or 7 days, or a urine output of less than 0.5 millimole per kg per hour for 6 hours. In this case, there is need to classify now the acute kidney injury. It is classified in an acronym known as REFILE model, where R stands for the risk, I stand for the injury, F stands for the failure, L stands for the loss, and E stands for the end-stage renal disease. It is an acronym commonly used in acute kidney injury network, meaning AKINI, which is a modification of the REFILE classification. Both the models, the REFILE and the AKINI, are model which are used in serum creatinine and urine output to validate the GFR. The REFILE classification of the acute kidney injury, it has several classes. We have the risk stage 1, which is the risk stage where we have a serum creatinine of 1.5 or a GFR decreased by greater than 25%, which is followed by a urine output criteria of less than 0.5 millimole per kg per hour times the 6 hours. We also have the injury stage 2, which is a serum creatinine of times 2 or GFR decreased by greater than 50%, with a urine output of less than 0.5 ml per kg per hour or 12 hours. We have stage 3, which is the failure stage, with a serum creatinine of times or 4 milligram per dl, with a urine output of less than 0.3 ml per hour times 24 hours, or anuria times 12 hours. We also have the loss stage, which is persistent acute kidney injury, complete loss of kidney function greater than 4 weeks. We also have the end-stage kidney disease. Now where you are declared now your kidney is not functioning well, which is greater than 3 months. That one was the REFILE classification. Now we go to the AKINI classification, which clarify acute kidney injury in stage 1, 2, and 3. And in stage 1, we have an increase in serum creatinine of more than or equal to 26.4 millimole or 0.3 milligram per dl, or increase to more than 150% to 200% from the baseline, and a urine output of less than 0.5 milligram per kg per hour from more than 6 hours. We also have the stage 2 of the AKINI classification, which is an increase in serum creatinine to more than 200 to 300, and urine output of less than 0.5 millimole per kg per hour for more than 12 hours. We also have stage 3, which is a serum creatinine of more than 200 to 300%, and a urine output of less than 0.3 ml per kg per hour for 24 hours, or anuria of 12 hours. It's good to note the classification, the REFILE classification, and the AKINI classification. They are very, very, very important classification in the acute kidney injury. With that well said, we now move to the signs and symptoms. When do you know now the acute kidney injury is setting in? We have several signs and symptoms like the decreased urine output, although occasionally urine output remains normal. We have the chest pain or pressure. We have the jugular vein distension. We have fluid retention causing edema in the legs, ankles, or the feet. We have the shortness of breath. We have the confusion. We have nausea, seizures, or coma in severe cases. So it's very, very good to understand the signs and symptoms of AKI. We also have the factor which predisposes a person to AKI. And factor number one is the age. There was a study done among the Americans of the older age, more than 70 years, and 15% of the population shown that uh, the the old age and the AKI. So why so? Why so among the old age? It is because of the the diseases associated with the age, like the diabetes, hypertension, and the cardiac diseases. As an individual grows older, there's reduction of the body organs like the heart, among others. Also, another predisposing factor, we have the nephrotic drugs, such as aminoglycines and contrast agents. These agents can cause AKI. And to avoid AKI when using these nephrotic drugs, they should be administered carefully with dosages tailored to the patient's conditions. So take note on that. Nephrotic drugs, they should administer to the patient when being monitored to avoid them triggering the AKI. The term AKI is acute kidney injury for those who are joining the studio. Also, we have predisposing factor number 3, which is now the infections. That is a sepsis infection. What happens when a body has infection? It is that the body depends solely on the heart for the supply of the blood to the kidneys. And once the body has infection, the blood pressure goes down. What will happen if the blood pressure goes down? The cardiac output will be too low. And this cardiac output, the kidney work hand in hand in the supply of the blood from the heart. So when it goes low, the GFR will go down, thus leading to AKI. So take note of the infection affecting a person, leading to decreased blood pressure, leading to decreased cardiac output, and in that case, leading to acute kidney injury. So sepsis disrupts blood flow to the kidneys, and not only to the kidneys, but also to the gut and the liver. There are other factors which predisposes a person to AKI, and this leads us to something we are calling the pathophysiology of acute kidney injury. There are 3 factors. We call them the prerenal factor, that is factor number 1. You have the intrarenal causes, and we also have the intrinsic causes. So it's very, very important to understand these causes. And in the prerenal factor, we have the decreased renal blood flow resulting from sepsis, as I explained there above. Sepsis is a form of infection in blood where the blood in a layman's language gets dirty with toxin or waste products like burn urea nitrogen. I've explained the issues of these sepsis leading to decreased blood pressure and decreased cardiac output. So in the prerenal factor, what is affecting it most is the sepsis. We also have the intrinsic injury known as acute tubular necrosis from sepsis also. It is a renal ischemia. Those who are very familiar with the word ischemia, it's like cutting the blood supply, maybe to the heart, the same to the kidneys because of the reduced cardiac output. So this is caused by the nephrotic drugs I talked about there above, which I said they should be used in care because if administered without monitoring or according to the disease condition, they can lead to intrinsic kidney injury. You also have the postrenal. The postrenal factor is mostly affected by the obstruction. Obstruction of tumors, which affects the organs, that is the kidney. They're the ones which lead to the postrenal obstruction. You also have the 4 cases of acute renal failure. And these phases occur differently. We have the phase 1, which is the onset phase. It occurs due to things like burn, loss of, that is, you can lose a lot of fluid through vomiting. They can also occur through diabetic insipidus. They can also occur due to decreased urine output of less than 0.5 millimole per kg per hour. And this onset phase occur hours to days. So it's also very good to understand these 4 phases. I have talked about the factor predisposing a person to AKI. So for you also to understand how AKI occurs, it's also good to understand these 4 phases, these phases I'm talking about. The onset phase. We also have the oliguric or anuric phase. Anuric phase is urine output which is lesser than 100 ml. There is amount of urine a person is supposed to produce in a day, which we'll discuss later with our panelists in the discussion after I'm through with presenting. So it's very good to understand what is anuric phase, the oliguric phase, and this phase occur 8 to 14 days or longer depending on the nature of the AKI and dialysis initiation. You also have the diuretic phase, which causes AKI, and it is greater than 14 days. You also have the recovery phase, which is due to decreased edema, normalization of fluid, electrolyte balance, return of GFR, and it occurs several months to years. Good to know those phases and predisposing factors. Well, with that said, let's go now to the complication of acute renal failure. Which complications occurs? Number 1 complication is the protein and electrolyte loss, which leads to malnutrition. If you are following yesterday's discussion, my colleague Evelyn Maro talked about malnutrition in the renal diseases. So you can go back to our Facebook page and note that is Nutrition and Dietitian Academy. That link was sent there yesterday. So if you don't understand the malnutrition in kidney disease, you can go back there and get the link. Protein and electrolyte loss also can lead to poor rehabilitation. It can lead to fatigue, anemia, and infection. What causes this complication of protein and electrolyte loss is inadequate protein or caloric intake due to anorexia and bulimia, altered taste, metabolic acidosis, inflammation, and reduced dietary intake. That's what causes now the protein and electrolytes loss. We also have the complication number 2, that is the muscle clamps. Muscle clamps is caused by removal of large amount of fluids. Why? This is the issue of anions and cations circulation in the body. Like calcium is very, very important in contraction of muscles in the body. What happens maybe in dialysis or in other form in treatment of acute kidney injury? There are those drugs which aid in removal of important nutrients like calcium or potassium. So if these important nutrients are removed, there will be little or no construction of the body muscles, because there are those contractions which solely depend on these anion and cations in the body. So note that. Also, complication number 4, we have the nausea and vomiting. These occur due to as a result of hypotension and other forms. We also have headache, which is a result of hypertension or too much fluid removal. With AKI, as if you're following my discussion, I talked about signs and symptoms. I discussed about the issue of vomiting and all those. So if there is a lot of fluid removal in the body, there will be no water balance. And there are those hormones which regulate the water balance in the body, like, and the antidiuretic hormones and so and so. So these hormones will trigger a balance of water in the body. And once they trigger the balance of water, if there is no water, the body will start using the blood as water. And this will trigger thirstiness. And in that long discussed story, to cut it short, it will lead to things like headache, because dehydration can lead to headache in one way or the other if the physiology is well understood. We also have another complication known as the chest pain. It is caused by ischemia. I think ischemia is the cut supply of oxygen and blood supply to an organ. It can be either to the brain, to the chest, so leading to this chest pain. Maybe because of the to the causes. It can be the prerenal cause, the intrinsic cause, all those factors. Also, we have another complication, the hypertension. Why hypertension? It is the cause is fluid overload prior to dialysis. Uh, this can be as a result, maybe someone is not taking medication well, or the person have not gone for dialysis for long, maybe because of lack of money, or the person is not able to reach the hospital in good time. As you know, the dialysis centers are very few, so the body continue accumulating the fluid because the kidney nephron are not functioning well, because maybe even the AKI may have gone further and become the chronic kidney disease. With that saying, now we can go to the consequences of the acute kidney injury. Which consequences does acute kidney injury cause in our body? There is altered composition of blood and urine. The altered composition of blood and urine in form of electrolyte and nitrogenous waste, because they are not well filtered out of the body. Also, we have the oliguria and anuria. Too little urine, uh, which causes the fluid and electrolyte imbalances. We have the sodium retention and edema. We have the hyperkalemia, which can cause altered heart rhythms or heart failures. Uh, because as I explained earlier, the issues of anions and cation in contraction even of the heart muscles. We also have the phosphatemia, which leads to bone calcium loss. My colleague will talk about the renal bone disease. Keep following. I think you'll understand more about the bone loss in the renal disease, the issues of phosphorus, vitamin D, and calcium regulation in the body. That is another topic which will still come. Let me not exhaust about it. Also, another consequences is uremia. Uremia is the nitrogen compound accumulating in the body, and various other wastes which accumulates in the body causing azotemia. That is waste in blood. And you know, once the waste accumulates in the blood, there will be sepsis. And once sepsis occur, there will be decreased glomerular filtration due to decreased cardiac output, thus causing AKI. Good to note that. Also, we have the test or the diagnostic test which are used to determine whether a person has AKI. Research is still being done on the same to explain on these biomarkers. And biomarker number one is the neutrophil gelatinase associated with lipocarine. These are scientific ones. And how does it detect whether a person has got AKI? The NGL level in renal tissue rises dramatically after the kidney experience poor perfusion or ischemia. We also have cysteine C, which freely filtered and reabsorbed in the proximal convoluted tubule. Cysteine C is detected in both the urine and serum. We also have elevated serum levels, which have been found to be acute kidney injury predators. We also have tissue inhibitor metalloproteinase. This is a biomarker appears in the urine within 12 hours after renal tubular cells are injured from ischemia or sepsis. We also have GFR, which is a biomarker which reflects directly in the urine output. The normal GFR, as I said, it depends on the cardiac output, that is the heart. Decreased BP, blood pressure, that is decreased cardiac output. Increased BP, increased cardiac output, and so on and so on. So, which is now the treatment of acute kidney injury after looking at the signs and symptoms, the predisposing factor, the pathophysiology of the acute kidney injury. Now, what do you use to treat this disease? The treatment can either be drug therapy. We'll see the several drugs used. It can be dialysis. I won't talk more about dialysis because there is someone who will talk about the topic. There is also nutrition therapy, which is very, very important and which is very major in our nutrition and dietitian academy. So that is the most emphasis where I put because nutrition therapy is very important in renal management. As you know, renal management is a multidisciplinary. It involves nurses, nutritionists, and so many people in the hospital setting. So it is very important to understand the treatments used, because even talking to a person is a form of treatment to patient with acute kidney injury. So which are the aim of the treatment? It is to restore fluid and electrolyte balance, and on the other hand, minimize blood concentration or toxic waste products. The treatment is highly individualized. Because why is it highly individualized? Because what presents with one person or with one patient is different from what will present with another patient. So it is very, very important to understand the treatment for each individual. So, when prescribing a drug, what should you look at? You should look on the cause of illness and complication. You should look on the immunosuppressant inflammatory conditions. Immunosuppressant here applies to the cases of the kidney transplant. It's very, very, very important to understand what is happening to this individual in case of the kidney transplant. You also look to things like diuretics, edema. There are those which increase edema. It's also good to look to potassium exchange, and because of the issues of hyperkalemia. It is also good to look about the issues of phosphate binders, high serum phosphorus, bicarbonate, and acidosis. So which are the most used drugs? The most used drugs, we have the several, and the most area I will emphasize about is the nutrition side effect of each drug. Drug number one, we have the furosemide. Indication, it causes edema and fluid overload. Action point is the loop. It's a loop diuretic. My fellow scientists who understand well the section of the nephron can understand where the ascending and descending loop is, for you to understand where the furosemide point of action is. So, which is the nutrition side effect of the furosemide? Number one, it can lead to urinary loss of potassium. It can lead to zinc and magnesium, calcium and sodium loss. And also it can lead to dehydration. What do? We will see there later when discussing about the management what we'll do about the potassium, the zinc, the magnesium, since now it is lost by the use of a drug by the name furosemide. We also have other drug known as thiazide diuretic. Indication is hypertension. Action of thiazide diuretic is potent diuretic, prevent reabsorption of sodium, potassium, and chloride. So, if this is prevented from being absorbed, what will happen? It will cause nausea. On the side of nutrition side effect, it will cause nausea. It will cause anorexia. It will cause hypernatremia, hyperkalemia, hypercalcemia, and hyperglycemia. We also have another drug known as spironolactone. Spironolactone indication is hypertension and fluid overload. And the side effect on the side of nutrition is hyperkalemia, dry mouth, nausea, vomiting, gastritis, and diarrhea. Another drug is calcium. And on the side of nutrition, the side effect it will cause it is constipation, increased calcium chloride, hypercalcemia, calcium citrate increases, nausea, and vomiting. We also have another drug known as aluminum hydroxide suspension. What does it do? It binds the phosphorus from ingesting food in the gut and prevent absorption. It should be taken with meals while restricting phosphate intake. So the nutrition side effect, it causes constipation, aluminum toxicity, increased thiamine requirements, impair iron and folate absorption. We also have angiotensin converting enzyme. Indication is hypertension, heart failure. It acts by inhibiting the production of angiotensin vasoconstrictor. So it causes a nutrition side effect of hyperkalemia. We also have beta blockers. It is another drug. Indication of hypertension. And the nutrition side effect, it causes abdominal discomfort, flatulence, induced hypoglycemia, lowering of HDL cholesterol, and increased total cholesterol and triglyceride. We also have another drug which is alpha blocker. Indication is hypertension. On the side of nutrition side effects, it causes low LDL. So, which is the goal of nutrition management on this now, on the acute kidney injury? We need to focus on increasing the energy levels. You also need to focus on increasing protein and micronutrients to prevent malnutrition. You also need to preserve lean body mass to maintain the nutrition status. We also need to avoid further metabolic derangements. We also need to enhance wound healing. We also need to support immune functioning and reduction in mortality. So, in the nutrition part, which is the nutrition assessment? Which nutrition assessment should be done to this patient who comes in the hospital? One without knowing or knowing this person has got AKI. We have the anthropometric, that is the usual use of actual body weight, if normal, or body mass. or ideal body weight if overweight or critically ill. We have the use of biochemistry if available or indicated or part of the routine monitoring. The patient may be admitted in the hospital and the interdisciplinary team don't know what is happening to the patient, but once lamp tests are done, they will show, as discussed there above, that maybe the patient now has acute kidney injury. We also have the full blood count on the nutrition part, which can be used in assessment. We have sodium, potassium, chlorine, urea, and creatinine. We have serum triglyceride, serum glucose, C reactive protein. We also have albumin. We also have signs and symptoms of fluid overload. We also have abdominal distension and discomfort. We also have blood pressure, which a nutritionist can use. We can also use the diet history, dietary intake. That is, it can be 24-hour recall or food frequency questionnaire. We also have dietary intake prior to the hospital admission or when the last meal was taken. So which are the nutrition? Now we have done the assessment of the patient. Which are the nutrition requirements? What does this patient who has acute kidney injury requires? The patients require energy and protein. Energy requirement is 20 to 35 kilocalorie per kg per day with monitoring. Protein should be given 0.8 to 1.0 gram per kg per day, non-catabolic, and 1.0 to 1.7 gram per kg per day for catabolism or dialysis. Also, we have fat, which should be 30 to 35% IV or 0.8 to 1.2 gram per kg. And it is very, very important to monitor serum triglyceride to monitor serum triglyceride. Another nutrition requirement is the carbohydrates. It should be 50 to 60% for critically ill. We also have a sodium, which should be 2,000 to 3,000, increased as depending whether the person is on dialysis or the person is not doing dialysis. So you should monitor sodium very well. Also, we have the fluid per ml per day, which should be output plus 500 to 750 to maintain balance. You increase fluid during dialysis. That is 500 to 750 plus 1,000 ml to maintain balance. Nutrition requirements continue. We also have potassium, which should be 2,000 to 3,000 nins, may increase with dialysis, or anabolism. We also have calcium, which should be given per milligram per day. We also have phosphates, which also should be given 10 to 15 milligram per day. We may also need phosphorus binder, that is 10 to 15. And they may increase with CRRT. You also have copper and among others. So, which is now the monitoring checklist after now you initiate the patient with all those requirements, nutrition requirements, or should you be checking on the patient? Because this patient needs to be monitored. Since the patient is using drug, the patient is using the nutrition requirement, what should you monitor? There are parameters which should be monitored accordingly. Number one is the anthropometric. It depends whether the patient is stable or unstable. For the unstable patients, weight should be monitored 1 to 2 times per week, depending on how stable the patient is. And for the stable patients, it should be monitored 1 times per week and daily to monitor changes in fluid status. You should also monitor biochemistry, that is serum, potassium, and sodium. They should be monitored daily. So serum, urea, and creatinine for the stable, for the unstable patients, serum, urea, and creatinine should be monitored daily, and also for unstable patients should be monitored daily. Full blood count should be monitored daily for the unstable patient and 1 times per week for stable patients. For unstable patients, blood glucose should be monitored 4 hourly. For stable patients, it should monitor daily. Serum albumin should be monitored 3 times per week for unstable patients and 1 times per week for stable patients. C-reactive protein should be monitored 2 times a week for unstable patients, 1 times per week for stable patients. Abdominal distension and discomfort should be monitored daily from both patients. Fluid intake and output should be monitored daily for both patients. Signs and symptoms of edema and dehydration should be monitored daily. Stool output and consistency should be monitored daily, and urine dipstick and microscopy should be monitored daily. With all that said, in summary, acute kidney injury needs a lot of nutrition support. It should be integrated as an overall view in energy, protein, fluid, electrolyte metabolism, among others. So nutrition is very key in management of acute kidney injury. Nutrition should be started very early after the injury, and it varies between individuals to an individual, depending on the degree of the renal disease or the comorbid illnesses associated. Therefore, there is no standard dietary regimen that can be used for all patients. So each patient should be managed differently. Thank you so much. I think I'm through with my presentation. Unless there is questions, I'm done.
Um, Thank you, Susan. We can take rounds of comments from Penina, Lorraine, Mwalo, Irene. So we can take comments.
Questions? Rorin? Any input? Addition? Clarification?
I don't know if you did talk about this, but there is this aspect of replacement. It's really not replacement therapy, but the CRRT that happens in AKI. I don't know if
I can't
anyone
hear
can
you well.
talk about that.
I can't hear you well. Come on. Rorin? Rorin? Eve? Evelyn? Have we lost Lorin? Have we lost Lorin? Come up again, Lorin. I think we have lost Lorin. Any other person with a comment or an input? Is Priscilla around? Evelyn, can you hear me? I don't. If no one is answering, I don't think there are questions on the chat box. I can't see the questions. Evelyn, do you have any comment? Miran, have I lost everyone?
Okay. So I think you've done a good job. I think thank you for the wonderful presentation.